Thank you, Professor. Prepare the vessel, perform atherectomy, lithoplasty, followed by DCB therapy may be the answer. I'm not sure what the question was, but I'll go forward. The problem with calcium, Fabrizio did a great job of outlining the scoring systems and the issues around managing that. But the issue is really that it's ubiquitous. It's especially troubling in patients with renal failure. It's increasing with age and complexity of our population. And most importantly, we don't have a lot of data on the treatment of calcium exclusively. Most of these trials that you've seen presented today in DCB, DES, whatever, really excluded severe calcification as a primary issue. And we know well that calcification is associated with dissection. There's a plane which is, moves from stiff to pliable, and balloon angioplasty doesn't always work well there. In addition, when stents are placed in an underexpanded, undertreated, or underprepared vessel, it typically will lead to underexpanded stents and fracture and restenosis site. We talked about this already. The last point here is the important one, which is that, and I've not used Fabrizio's slide, which everybody knows well, but calcification appears to limit the effectiveness of drug transfer from drug-coated balloons, both in cadaveric models and Dr. Fabrizio and Dr. Fanelli's study looking at this circumferential arc of calcification as a increasing severity of reduced drug-coated balloon efficacy. And here's really the issue. You have to take a balloon to high pressure. It may or may not work. You're going to get dissection. It may crack the calcium, it may not. You may perforate the vessel, but you will definitely injure the vessel at an increased level than you would have otherwise had to do. We also know that calcium is prevalent in real-world studies. This is from the IMPACT Global Long Lesion Cohort, which has been referenced before. You can see that severe calcification was present in 20% of the patient population, and according to lesion length, increasing levels of stents were needed to be used, associated with the increased complexity, including calcification. So it appears that adequate preparation is useful before stent implantation and or DCB usage with atherectomy or potentially other methodologies. There are multiple ablation technologies, and I would submit that none of them has been specifically tested. Oh, there you go. Any chance we can get that back? Can I call a friend? Well, I can go on. So basically, none of the atherectomy technologies have been specifically tested in the most severely calcified lesions in terms of how they do in long-term outcomes. But you can see that they all have their different qualities. Eczema is pretty good with thrombus. Less probably good with calcium. Directional atherectomy has been developed for calcium cutting. Aspirational atherectomy, jet stream, does work very well in calcium. We've published on that. The rotational atherectomy rotablator was engineered for calcium. An orbital atherectomy system also engineered for calcium, but these really more in the coronary circulation, not so much in the SFA popliteal, as you know. We do have a study that looked at atherectomy and paclitaxel-coated balloons in the definitive AR study. This was published a couple of years ago, actually a year ago now. I would just remind everybody that it was an important study, but relatively small, 121 patients enrolled. Most of the patients were selected as not severely calcified, so 100 of them were not severely calcified, they were randomized. And the non-randomized arm, and non-randomized, so we have no comparator, the severely calcified lesions, there were only 19 or 20 patients in this arm. So again, not a lot of data. And when we look at the primary patency in the non-randomized calcified arm, 50% at 1 year, which is not terrific, and certainly substandard compared to prior studies with DCB at 1 year. Good news is that there are data coming for us. The reality study, which has been initiated by the Viva physicians and sponsored by Medtronic, is a directional atherectomy plus DCB in long calcified femoral popliteal lesions. And this is an important study because it will help us understand better the utility of atherectomy in calcified lesions, especially the TurboHawk, Hawk1, and the DCB. This is a non-randomized trial, so we'll have a good look at some outcomes, but not as a comparator function. The JET Ranger study by Nick Shamus is going to be a randomized trial, rotational atherectomy plus DCB or POBA, and that's the randomization component. And so we're going to find out not only does atherectomy work in conjunction with balloon, but balloon versus DCB in terms of the longer-term outcomes. So this is going to be an important study, and it's going to really fill in a lot of the gaps that I've already outlined here. Problem with atherectomy, however, it can be effective in removing some of the plaque, but it can be tough to use, time-consuming, radiation exposure. It can be expensive. It can require, as you've seen, filter adjunctive protection, which is important. It may not be possible to modify or remove all the plaque, and I think PK showed that very nicely with his IVUS in the earlier case today, and has not been really materially shown, as I showed you with the definitive AR study, to improve the long-term issues with calcium, especially with restenosis. So Shockwave comes along as a lithoplasty offering heavily calcified lesions in the studies that have been done to date. I just give some examples. This is actually a video, so it's moving. Watch it carefully. It's a 4 to 6 atmosphere balloon inflation of a calcified lesion, and the lithoplasty has been turned on, and you can see that the lesion is now being dilated at a low pressure. And this has shown to be quite effective in these calcified lesions, but also in reducing the need for stent, as I'll show you in a moment. The Shockwave does have data, like atherectomy is being developed. The PAD-3 trial is now currently underway. That's a Shockwave plus POBA versus versus DCB. And we're going to see whether or not there's a long-term effectiveness, as well as what POBA looks like versus Shockwave alone. And we do have PAD-1 results. Procedural success was quite good. This was a European study. Device success was good. Clinical success was excellent. ABIs improved by 0.3. Rutherford class improved by almost 3 grades. And freedom at 6 months from TLR was quite good, with primary patency of 82%. So we know also that both in PAD-1 and PAD-2 studies, which were the early feasibility studies in Europe, that while there was a 3 millimeter gain in Shockwave treatment, there were no stents having to be deployed. So this is the PAD-3 study, as I mentioned, lithoplasty versus POBA randomization, plus DCB in both arms, and we're going to have hopefully a completion of that trial later this year. So in summary, calcium is becoming more ubiquitous in peripheral arterial disease intervention as the populations become more clinically complex. Calcium is a marker for poor outcomes, increased stent usage, and reduced antiproliferative effectiveness. And while adjunctive therapy with atherectomy or lithoplasty can improve the acute outcomes and reduce stent usage, it remains an open question as to whether longer-term results are benefited. Thank you very much.